All right, good afternoon, everyone. We're here today to talk about how you should stop cleaning your identity data because you can achieve interoperability of patient information despite dirty data and out-of-date data. Before we get started, I just wanted to get some housekeeping items out of the way. If you have any questions, you'll see a chat box where you can submit them. I'll field the questions and feed them to our speaker at the end of the presentation. If you missed something or want to share this session with a colleague, we'll also be recording the webinar and it'll be available online after the show. I will send an email to each and every one of you with a link to that recording. Now I'd like to introduce our speaker, Brent Williams. Brent is Verato's founder and CTO. He has a broad background in the world of identity integrity, including work in the healthcare, credit, telecom, and government arenas. I could say a lot more about Brent, but we really don't have enough time for that. So with that, I'll go ahead and hand it over to Brent Williams. Brent?
Hey, thanks, Ray. I really appreciate it, and thanks everybody for your time this afternoon or this morning. So I want to start off with the basic premise that, you know, I'm a big proponent of clean data. The challenge is, and it's a lot of what our discussion is going to be today, is you need clean data traditionally to do accurate and consistent patient matching. So if you want to make sure records match, or you want to make sure bills or financial transactions match related to patient data, the concept of being able to link those records consistently and accurately is necessary for solid care coordination, longitudinal care history, which in the end impacts care quality. And what we find as we go out and talk with our clients and prospective clients is the fact that the current approaches, which tend to be a very a manually intensive data review process, or largely depend upon data governance or data updates by the end user, end up being very, very large exercises from a financial and a time commitment. They do yield positive results. So again, the concept of making everybody's identity data correct does enable the matching process to work better. But the challenge is the cost and the complexity at which that comes along. And so consequently, what we want to talk about today is a lot of what we talked about at HIMSS and in our work with our customers is how can you affect the desired care coordination, care quality impacts by making real-time, highly accurate, highly consistent patient record matching and linking possible in today's world, given the extent of technology that's out there today. And then actually tie that improved performance to the improved healthcare outcomes that we expect as part of that process. So with that, what I'd like to do is dive in to a basic scenario where two institutions want to be able to share information about a patient. The institution on the left sends information, a request to the institution on the right saying, do you have health information for this person? That institution takes the PII, or the descriptors or the enumerator for that individual, attempts to match them, and if there is a match to the patient, then they return that information back to the requesting institution. This process could occur inside an enterprise. It's the centralized health record system talking to the billing system, or the laboratory system, or even chemotherapeutics or PACS. But as part of this process, you know, the challenge is, how do we actually make sure that we avoid doing redundant testing, redundant procedures, and so the integrity of this process is critical. With a false negative, we actually incur that problem. So here on this slide, what you see is the fact that I went to look for patients in step one, and when I looked for that patient, I didn't find a match. And we find that a lot of institutions who are doing matching on biographics coming over from another institution actually will tune their algorithms so much to prevent a false positive that they end up yielding a substantial amount of false negatives. And when that happens, of course, you get no health information returned to a request that you should have had health information returned, and then that then yields the negative and potentially drastic consequences of the lack of proper information sharing either within or between enterprises. Further, another concept that we'll talk about today is the concept of a false positive. In this particular case, you send over the biographics on an individual, Sally Smith, and because you don't have your twin algorithm configured properly, or you've got a parent-child mismatch, you end up yielding a false positive, and then you return another patient's health information. So that, similar to a false negative, what you're using is incorrect medical history in order to make some sort of clinical decision. So if you think about the different scenarios that exist here, is you've got the accurate approach where there is a true positive, you've got a false negative, and then a false positive. And those are the three potential scenarios we'll see in health information sharing when we do that. And our assertion is, just as bad as a false positive, false negatives can yield equally disastrous outcomes as part of the care process. I'll add, I actually was sharing this discussion with a colleague today, and in that discussion, one of the areas where false positives are equally as disastrous as false negatives is the whole idea that I put up a PHR, a personal health view of a person, and I put another patient's information into that, yielding a HIPAA violation in that particular case. So, you know, this is bigger than just the care events, but it's also protecting patient privacy and security. So, what do we need and what have we done to achieve trusted health information exchange? Well, the core needs for trusted health information exchange is built on this concept of technical interoperability. Everybody that is on this call, or folks that we work with, have all experienced, whether it's HL7, NHIN, FHIR, ISO standards, the ability to connect the institutions so that they can send messages back and forth is all well and good, and a critical first step in achieving trusted health information exchange. The next piece of it is actually getting past the being able to send messages and making sure that there's interoperability at the document exchange level, so that there's an interoperability that makes sure that the information being sent from one organization is understood from another. And again, a dramatic work has been done over the last 20 to 30 years on document standards, everything from SNOMED, DICOM, NCPDP, in order to be able to create a common understanding, whether it's system to system within an enterprise, system to system outside of enterprises, or even like ICD-9, ICD-10, and CPT codes, where you're actually using it as part of a business process where you're sharing from a healthcare institution to a paying institution or a payment processing institution. That we've got to make sure that even those accounting transactions match on the far side, that the patient IDs and patient enumerators get there. And so that really brings up the final domain of trusted health interoperability, is the concept of identity interoperability. So when we talk about in the technology world of achieving semantic interoperability, once we have technical interoperability and connect the systems, we have documents to make sure we can all commonly understand each other. We still need to make sure the system actually works. And so when you have proper patient matching and patient addressing on either end of that, what you get is no false positives and minimal false negatives, trying to seek no false negatives as a piece of that process. So now you know you're getting the right information when you ask for it, and you understand that information, and it's there and available. So expanding on that identity concept, what we have here is a view of health records. And those health records, think of them as like the payload on an IP packet, where there's this substance of information that we attach to an individual. And we attach it to an individual either by using some common enumerator through the enterprise, or a billing enumerator like an insurance ID. But in the end, when we're sharing information across enterprises or between systems, rarely do we have the same enumeration scheme, and so consequently, we tend to put in name, date of birth, address, and might use something like a social security number to get there. And when those pieces of information are exactly the same or close enough, and that metric of close enough varies dramatically by institutions, we do have identity interoperability, and we can be sure that the systems can communicate with each other. The challenge is, as any of you on this call have experienced, is the reality is identity information is rarely that perfectly stable, hence why we're talking about this data quality issue. And what you see are just basic name changes and address changes over time. I've got a maiden name because I changed my last name when I got married, or I hyphenated my name. I've got old addresses in that data set, so that there's a natural evolution to the underlying data set. There's also the concept that errors are introduced into the process. You know, I mistyped a birth date, I've got a European to US error, or you know, the funny thing about birth dates is you were born on one day, but even different cultures interpret your birthday as being something different. And so we see some very interesting errors in that data. And then similarly, we have the ambiguities that are introduced by junior-senior overlap. Father, son have the same exact name. Twins, very similar names. I was dealing with Shaniqua and Shaliqua, which is technically a Levenstein 1 error in their names. It's just one letter difference. They were one SSN apart, same address, same date of birth. And of course, we all try to deal with that problem. Another one we see frequently in ambiguities is with Hispanic and Asian naming conventions. If you've got a Hispanic male, usually they'll have the maternal and paternal name separated by a space. But on some of the legacy mainframes that we deal with, they don't like spaces in the last name. So we'll either hyphenate them, which is actually an incorrect version of their last name. We'll concatenate them and jam them together, or potentially we'll take the maternal name and drop it in the middle name field. Now we've come up with schemes to tokenize those names and test to see if they exist across all of those, but they don't catch the right mixture all the time, and not everybody develops against those. And so consequently, when you look at those errors, as well as, you know, other errors that occur in the clinical environment, like entering 11111111 as somebody's SSN, and then somebody writes an algorithm in their system to say don't allow repeated numbers, then they enter 121212, and then when they say don't enter proximal numbers, somebody does 123 123 123. So you see that these patterns in data when we walk into our customers and see these errors. Trying to write rules that that fix it is difficult, because there'll always be a new way to get around that rule. In fact, what we end up seeing is that of all these errors, and we kind of seen these general numbers across all of our customers, you know, the population moves roughly between 10 and 15% per year, and then the ambiguities that exist due to names are actually expanding as our culture diversifies. And what that yields is somewhere between 30 to 40% of all medical records have identity errors. Now, how far off are they? Are they just one letter off and we allow that in our matching algorithm? Are they so far off that we can't match? And so we see that tremendous impact in the data. Now, this is where we spend a lot of money on data quality exercises, but when we look at this data across all of our customers, what we know is that when we bring in these large-scale data sets, we had 120,000 people born in the 1800s. Those people are not receiving medical care in our system anymore. They shouldn't be. And nearly 5 times as many birth dates are recorded as being on January 1st. I had one customer that it was actually 25 times. And it turned out it was an error introduced on due to a Y2K transition, but routinely somebody will enter the year and the system will automatically pick January 1st given no other information. Further, humans put those errors in the data. And then we also see this whole concept of misnomers in data or errors in data. And one of the funny ones here, if we talk about it, is this whole idea that we don't know which one's right, Sarah with an H or Sarah without an H. It may be one way on your birth certificate, it may be another way in your hospital records, it may be another way in your medical records. But the fact that it could be either, and one may or may not be an error, is very, very important. For example, my father-in-law goes by the name John, and he's one of those rare Johns who does not have a full name Jonathan. And how many times people have corrected that in his records to be, as part of a data quality exercise, to be Jonathan actually is correcting it incorrectly. So in looking at that, we looked at the ones that, the identities that should have matched. And this is a characterization of the errors that were extant in the non-matching records. So, you know, again, I go back to the birth date concept. You were born on one day, and 1.3% of the time, the no matches actually existed where the birth date was completely wrong. 7% of them had a last name difference. That last name difference is usually a maiden name issue, but it could also be that Asian or Hispanic name translation. And then lastly, there's the concept that 13% of them had a substantially different address. So this isn't just I mistyped the number, this is a completely different address. And so consequently, because there might be multiple Juan Garcias. So for example, we do a lot of work in Southern California. Juan Garcia is a common name. We even have instances where there are 20 Juan Garcias in the same building. And so given just different apartment numbers or different street numbers on the same street, it makes it very difficult. So consequently, organizations choose not to match when they actually should be matching. And when you see across all those records, over 20% of records had at least one of those 3 critical errors, and lots of them had a lot more. Now, not only is it our work that we see these errors in the data, but if you look at CHIME, and CHIME is particularly valuable because they're looking at it from this whole idea of how do I match across institutions, and then also, you know, we see a lot of the problems that are coming up with how do you match kids when they're very brand new to the system and you don't have any way of knowing what the right answer would be. And so we're seeing that they are agreeing with an error in match rates of 10 to 20%. And then in the kid population, that even gets worse when they're trying to exchange. For example, a patient born at one hospital transferred to another hospital immediately after birth and for specialty care, and we get substantial failures in the ability to match. So what do we do when we actually want to go through a data quality exercise? And that data quality exercise, as I mentioned, is largely manual, and it is either we've tried to match, we looked at the manual cue for the matching, oh, you know, this one said John, this one said Jonathan, let's make them the same value so they match. That's one version of it. The other version of it is everybody uses the Ohio State driver's license. And so consequently, whether you're going by Joe or some of the doctors know you as Joe, one of the hospitals must put you in as Joseph because that's what's on your driver's license. And so consequently, when the data does not overlap properly, you get a no match. And the data quality exercise then forces us to go through and make the changes that drive the matching. This is particularly a problem when you look at an HIE that's dealing with 20 different institutions within the HIE and trying to achieve some sort of standardization through a data quality exercise across all of those different institutions. And so while data quality does get you to the match, the question is there a better way to do that? By the way, you see the fact that the Sequoia project even did measurements of this concept of data quality exercises do improve the matching across organizations. The question becomes at what cost, at what time delay, and does it enable real-time sharing or is it post-real-time sharing? And so we'll go into that a little bit as we go through the discussion today. So diving into this, when Sequoia Project looked at this, what ended up happening is we looked at the amount of time and effort that was required to cause an improvement in the cross-organizational matching rates. So initially, it's 10 to 15%. Through data cleaning and normalization, we jumped to 60 to 70%. Through algorithmic refinement and operational improvements, this is when you're actually catching the transactions as they're going on, you see upwards of 85 to 90%. And then doing pre-worked and reused correlations, as the Sequoia Project put it, they got above 95%, which is a great goal to achieve. But at the same time, I'm going to give you an example here of a customer that we have, that we had a patient that was at one hospital, and that same patient was at another hospital. At hospital A, they used the driver's license. At hospital B, they used patient self-reported information in order to get there. The interesting piece about this is patient in hospital B was actually transgendered. And so they go to hospital B for the surgery, for the procedure. Now they don't match across the two institutions. And so we started seeing this repeated error would show up where we would say that the two individuals match. The institutions, because of their data governance standards, would say that they don't match. And lo and behold, this was actually a substantive amount of the population where we discovered that the data governance was actually driving the no matching in the institution set. So this grows as we start looking at more and more hospitals, sharing with more and more other hospitals, the exchanges trying to share across different health systems, and even HIEs looking at this as it compounds up. This, as I mentioned earlier, HIEs don't solve this problem. It actually makes the problem even more difficult. So this is why we're here. This is why we're asking for your time today, is there's a new way to take a look at this, improving this matching process. And it goes beyond the traditional deterministic, which is, hard coding number A matches number B, or name, date of birth, SSN, and A matches name, date of birth, SSN, and B, which is a deterministic approach, or a probabilistic approach, which is they're kind of close. And what we do is a system called referential matching, which uses all the capabilities in deterministic and probabilistic, but takes it to a new level of matching accuracy in real time, such that you don't have to fix the data quality issues, because you really don't necessarily know what the right answer is, but we do know how that matching works. So in order to do referential matching, we utilize a gigantic database of identity data as references. Now, you can buy these kind of services and solutions from the large credit providers or marketing data providers, but what we've done is we've aggregated this data, whether it's credit header data, telco record data, and even government and legal record identity data. We don't sell it, but what we've done is we've applied a series of algorithms that we use not just to match the data, but actually to build the data set that represent human intuition. So I know that Sally Jones and Sarah Smith are the same person because Sally Jones started cohabitating with a person with a last name Smith, and Sarah and Sally are the same last names, but they were divergent. In other words, they had different patterns where Sally Smith didn't or ceased to exist and Sarah Jones started to exist. And so understanding what a human pattern looks like over time and aggregating 30 years of that data actually gives us the ability to understand what the normal patterns and interrelationships of those identities are over time and through variations. So two patients with very different data sets, and Sarah Jones, Sally Smith as an example, they actually overlay on the same person for us. And we're not using those traditional data sets, but we've actually gone through and used the matching algorithm to actually fix the errors in those gigantic data sets that are present just because they're using MDM or probabilistic matching on the back end of them alone, like the credit header data or utility data or otherwise. Now, the interesting part about it is, as the Sequoia project was looking at this data, what ended up happening is when you're looking at address attributes as part of the matching process, what ended up happening is, you know, within a hospital, the city, state, and probably the postal code don't actually vary a lot across patients. And so the great example here is the Juan Garcia in Southern California. There's a lot of Juan Garcia's in that particular area. And so consequently, trying to achieve distinctiveness was very, very difficult. Similarly, comparability of those becomes difficult because street addresses are typically full of, do I have address line 1, address line 2, and then add to it the fact that the stability of that information as it changes over time because people are moving is particularly difficult. Referential matching actually pushes through that barrier in the data. So every single data point that Juan Garcia moves from one apartment to another home, we know that there's one Juan Garcia that has one pattern and another Juan Garcia that has a completely different pattern. And so it's the combination of attributes over time that then create a distinctiveness in the individual. You know, one person said to me, is you go into a cocktail party and you say, hey, I graduated from the Naval Academy. Oh, I know somebody that was at the Naval Academy. His name is Bob Jones. Well, what year did he graduate? It was 1980. So you start asking for attributes and those changes over time to actually narrow down who somebody is. And we've replicated that in our referential matching system. And also that allows you to negate completely the stability issue in that data set. And so what that ends up enabling is this dramatic improvements in being able to pull together patient data across a wide variety of systems and facilitate much more accurate and trusted exchange of health data between organizations and even within an organization between systems. The output of that is the impact on care, on the cost of care, the outcomes, etc. And we've actually participated in studies and actually have done some analysis where when you're looking at outcome-based measures, because the course of care data is not accurately matched, and let's just say for argument purposes here, we're missing 30% of the data because it's in a different system. Now, for the math geeks in the room, that 30% actually works out to, if there's 30% error in one system and 30% error in another system, that means they're both 70% correct. And in pure math, that means that the combination of the two of them is 49% correct, which, you know, if I start sharing information between different organizations, that error compounds. Of course, it's not a linear scaling issue, but the whole idea is if I'm trying to assemble your health record from the time you were in DOD, the time you were in VA, you had some records in VA, plus you were at 5 different specialists and one community care clinic, being able to assemble that course of care accurately such that you can create outcome measures, they tend to be very granular, you know, or very non-granular, excuse me. You know, I treated him with this medication and we had resolution. You know, for example, CMS for the longest time, actually the measure of efficacy for a hip replacement or a knee replacement surgery was an outcome measure of, was the patient rehospitalized within the next 6 months? Well, there's a lot of things that'll get you rehospitalized, and then there are a lot of things that might have you rehospitalized in a different hospital that we missed. So what we have found is through improving the accuracy of matching, what happens is you're better able to differentiate the courses of care. What different treatment modalities, what different treatment regimens did you use for each of those patients? And therefore, the outcome measures, it's not just rehospitalization. I can actually now measure rehospitalization for a car accident versus rehospitalization due to infection versus rehospitalization due to bad joint matching of that hip joint. So without the granularity that's achieved through better matching, being able to get to those better health outcome measures is difficult. So, wrapping this all up, what we're suggesting and saying here is that there's a lot of data quality exercises and benefits from better data quality. They come at tremendous delays. They tend to be very academic exercises going back and saying, yeah, data quality would have been better. And what we have done at Verato is actually found a way to use our platform of referential matching to make that extremely accurate and in real time. So you're not spending time trying to fix these errors historically and at great cost. So in front of you, you see my Twitter address. Please tweet me, please friend me, because I'm in a competition with my kids to see who can get the most friends, and unfortunately my kids are a lot more interesting than I am. But given that, I'm going to open up the floor to questions. So Rachel, what's it sound like out there?
Yeah, we have a few questions lined up for you. The first one is a question about referential data sets. The question is, what services can provide such referential data? Can you name a few?
Absolutely. So if I go back to this world here, so we go out and acquire this data. And so, for example, credit header data is acquirable. It is very difficult to acquire. There aren't many people who have it, and you got to maintain a lot of security standards in order to have it. But it's essentially Equifax, TransUnion, and Experian that have that data. And as an example, I was formerly the CTO of Equifax, so I tend to know how to get that data and actually analyze it. At the same time, telco record data is really kind of interesting because when you look at the data sets that we put in here, credit header data takes a while to update. In order to get it in the credit header, you got to have a transaction at a bank where they either request a loan or you have a loan and it starts hitting your record over and over again. And that will sometimes take 3 to 4 months to even get into the system. So in the healthcare industry, one of the things that we really wanted to do was make sure that we saw a change in a record as soon as it occurred. So we went out and acquired telco data, go to the people who write the white pages or the people who sign up cable providers or electricity providers. And in that particular case, what we were able to see is the creation and the disconnect of utilities. Now, how does that help us in healthcare? So if I show up, I live in Washington, D.C. area, and I show up in Chicago and I give a new address, one of the things that we do as part of our matching algorithm is we say, wait, I don't know that Brent Williams has this address in Chicago. Let me look at the Brent Williams and see if the Brent Williams I think this is has actually moved and disconnected at his other address. And then the power of this tool is actually we test the hypothesis of, well, if he's moved to Chicago and this is his new address, we should see a disconnect of the prior owner of their house leaving that location. And part of it is also, is it a hotel, is it a business address, all those things that go into that. So the telco and utility data sets were particularly useful for us in order to close in the time window. So in a hospital, we're able to help our practitioners at time of care actually understand that real time. And then lastly, when you look at credit data and you look at utility data, there's a big chunk of the population that's disenfranchised. The first one is the under 18-year-olds. The other one is the people who tend not to have electronic relationships, the unbanked population. Another one that is problematic in there are recent immigrants, for example. And so we acquire government and legal record identity data. So where it is public data or acquirable data, we acquire it, so we find those edge identities that are not in the mass population. and what that does is it kind of leaves us with a chunk of people that, I've got a 4-year-old coming in. Now, a 4-year-old's not going to appear in any of these records. But the neat part about it is even the HL7 standards have been updated for next of kin and responsible party. And so many of our customers are actually getting to the point that we're actually creating seed identity, so we're aware of an identity. It's still private. We don't sell the data in the database. But if they have a first encounter with Jeffrey Brent Williams Jr. with a date of birth of 2005, then we actually know that there might be a kid who has the same name, same address, different SSN, and a birth date that generationally makes sense with the Jeffrey Brent Williams we know about. And so that's part of some of the fancy stuff we do with our data sets in doing that. Next question.
Thanks, Brent. The next question is, my organization is thinking about using biometrics. Won't that solve this problem?
Hey, yeah, that's really cool. I had a great past life in my career where I was actually worked on the biometric system that we use as part of immigration, so the U.S. visit system, and learned a lot about that. And one of the things that I found is that biometrics are just like probabilistic matching. So the whole idea is compounded and becomes a problem in two different ways. The first one is that I have to create a match template. So I have to enroll Rachel in the system and say, this is Rachel. Now the next time she approaches, if I know it's Rachel, I'm doing a one-to-one comparison with Rachel. And so I pull the template out that I think is Rachel, and I take either the iris or the facial biometrics or the palm scan, whatever I might be using, and I compare those two. And essentially what I'm doing there is I'm doing a counter fraud mechanism. Is the person claiming to be Rachel actually the Rachel that I enrolled at the first organization? If I use the palm scan of Rachel to find her, in other words, I don't even need to challenge Rachel as to what her name is, but now I'm just going to take her palm scan. I have to take Rachel's palm scan and find it in a repository of my patients. Well, you know, if it's a 10,000 person repository, a 1 to 10,000 search is actually pretty easy, and the palm scanning software doesn't have to be that good, so it tends to be fairly inexpensive. As the population of the one-to-many search goes up, 100,000 up to 1 million, we now get to very cost-prohibitive biometric solutions. Things that have to be so accurate and so well enrolled and so well maintained that finding you in that distance data set is very, very difficult. So the whole idea that the biometric is your identifier, it might as well just be another attribute, like your last name, or your last name and your social security number, your date of birth. Because in the end, I've got to find that cluster of attributes, and that attribute might be your palm print, in a great big repository of data about you that my hospital has. And then, God forbid, we actually try to share information with another hospital that uses iris scanning instead of palm scanning. And all we go back to there is deterministic matching between the two enterprises. So biometrics breaks down in a lot of different ways as being a end-all, be-all to finding patient records within an institution, and it's a severe impediment when you're trying to do it across institutions. So hopefully, as you're looking at this, you really realize you're still looking for an enumerator-based strategy, but if you're trying to share between systems, the biometrics doesn't actually solve that problem. It's much more of a much higher level of efficacy and a controllable cost as a counter-fraud, counter-impersonation capability. And hence, I wouldn't necessarily use it in that case. Next, any other questions?
I think we have time for one more. The question is, how much does an MPI cleanup exercise cost?
Well, you know, it's interesting. We've seen a couple of institutions do it, and so you got to kind of look at a couple of different versions of this. One institution that is a hospital system that is made up of a lot of different clinics, each of those having different EHR platforms, different enumerators in those, and then they're pulling the data back up to a centralized system. The way that they're doing this data quality exercise is they're centralizing, making sure they have a high match rate by using the Ohio State driver's license, for example. And in that exercise, every time you check in, the registration agent has to make sure that they check your current driver's license, and if it changes or if you're a new patient, they're manually entering that and then actually scanning it and sending it off to somebody to double check it, and then find across all the other systems what other systems have to be updated with your new name and new address if you're not a new individual. And that, 4 million patient organization was spending $3 to $4 million a year in manpower alone to manage that data quality exercise. Alternatively, we know of a large HIE that went out to improve the efficacy of how an HIE works. Listen, if an HIE can't find records across its different players, it's not doing a good job of sharing information. And so this particular HIE, large state-based HIE, spent $2 million on a one-time effort to go through and do a cleanup exercise. That was all great, and the sharing worked much better at that 90–95% accuracy level, but then 3 weeks later, it started degrading. And so every 6 months, they did this first $2 million job, and then every 6 months, they did another $500K. And so what we're seeing is between manpower costs and impact on systems and business process impediments is it's a multi-million-dollar exercise for a multi-million patient system, whether it's an HIE or a health system, in order to solve a problem. And if any of you participating actually have some of those statistics, we would love to be able to look at those and see if they mesh with what we're saying. So I certainly appreciate the questions. I know we're up against our deadline here, but feel free to reach out to us, listen to the webinar again, share it with your friends, and reach out to us directly through LinkedIn, Twitter, or directly to our info at our company, and we'd be more than happy to chat with you about the capability.
All right, well, thank you very much, Brent. That about concludes our time today. Just like Brent said, if you have other questions or want some clarification, please, don't hesitate to reach out, and you all will receive a recording as well, and please share that. Thanks again for joining us, and talk to you soon, hopefully.